up this afternoon. Please use the questions feature again to ask any questions that you have. And if we have too many questions that we can address during the course of the webinar, we'll work to publish a Q&A document after the webinar is over in order to make sure that everyone gets their questions answered. Just a little bit about us at Shared Action and Shared Action HD. We're funded by the Centers for Disease Control and Prevention to provide free trainings and one-on-one technical assistance for health departments on a lot of different areas: evidence-based interventions and public health strategies, monitoring and evaluation, organizational infrastructure and program sustainability, and the big one right now, obviously why you're here, is alignment with NHAS and HIP and HIV and AIDS services, and addressing NHAS, the Affordable Care Act, and all these changes that are coming to our agencies and our field. We'd like to acknowledge AIDS Project Los Angeles, the Centers for HIV Identification, Prevention, and Treatment Services at UCLA, and the Centers for Disease Control and Prevention for making this webinar possible. We're here today with three presenters. Keisha McCurtis is an implementation scientist and project director with the UCLA Department of Family Medicine. She has authored intervention manuals for linkage to care and re-engagement in care for men and transgender women living with HIV. She has also co-authored a series on social determinants of health and HIV and structural level interventions with colleagues from the Children's Hospital of Los Angeles. Keisha is a CDC-funded capacity building and technical assistance provider for health departments and CBOs and has extensive experience working and collaborating with traditionally underrepresented and marginalized communities. She is also steering committee co-chair of the HIV Prevention Justice Alliance. Our second presenter, Tom Donahoe, is an associate professor of family medicine and the director of the UCLA Pacific AIDS Education and Training Center at the David Geffen School of Medicine at UCLA. He is also the associate director of the UCLA Center for Health Promotion and Disease Prevention. He has an MBA in finance from the Anderson School of Management, and in the 1980s he worked as an investment banker on Wall Street working on mergers and acquisitions. Our third presenter, AJ King, is a senior analyst at UCLA's Department of Family Medicine and is also a consultant in the field of public health, providing grant writing, facilitation, training, strategic planning, and other organizational development services for a variety of community-based governmental organizations. AJ worked for many years as a trainer and manager overseeing a national CDC-funded capacity building assistance program for health departments and community-based organizations. He has served as community co-lead for the CBO for Health Departments National Network and as a co-chair for the Los Angeles County HIV Prevention Planning Committee. And without further ado, here are our presenters.
Great, thank you, Patrick. And good afternoon and good morning to everyone out there. Thank you all very much for joining us today. I'm going to start by quickly reviewing our objectives for today's webinar. By the end of the webinar, we anticipate that participants will be able to understand the new context within which HIV prevention and care services are delivered, identify possible strategies that agencies can apply immediately to orient themselves to this new context, and access available resources to assist with restructuring efforts. Our agenda then is to discuss the current context in the field of HIV and how it is prompting many of us to consider restructuring. We'll talk about what you can do right now to align your organization with national priorities, and then we'll hear from two organizations who have recently undergone some strategic restructuring or realignment. We'll wrap up by looking at the impact of the Affordable Care Act on HIV services, and we'll have a little time at the end to take some questions. As you may know, today's webinar is the second in a two-part series, and our entire agenda has been developed in response to the questions we received after our first webinar. Some of the questions we'll answer directly, and other answers or responses will be embedded throughout. So let's start with a quick poll to find out a little bit about who's participating today. I'm going to turn this back over to Patrick, who will conduct the poll. Go ahead, Patrick.
So the poll is, which you should be seeing shortly, which best describes where you work? A community-based organization, health department, federal agency, or other? And we'll give you guys a little bit of time to vote. We're around 50%. And I'll close it out in about 5 seconds. maybe a little longer. We still have those coming in. And closing in now. So let's take a look at the results. So we have around 48% of our attendees from community-based organizations, 34% from health departments, 0% from federal agencies, and 18% from other.
Okay, great. Thank you. Let's go to this follow-up poll, actually. If you work for a CBO, is your CBO connected to a clinic? Go ahead, Patrick.
The poll is launched, and the selections are yes, we are a clinic or have a clinic. Yes, we are connected with at least one clinic. No, we are currently a CBO without a clinic relationship, or I'm not sure. We're at around 40% votes so far. Give you about another 10 seconds. Okay, closing the poll. And let's take a look at these results as well. So around 25% are a clinic or have a clinic. 39% are connected with at least one clinic. 18% are currently a CBO without a clinic relationship, and 18% aren't sure.
All right, and one last poll that Patrick will again lead you through.
All righty. And this is a simple one. Did you attend our first webinar in this series, Strategic Restructuring the Affordable Care Act era, in January? Well, this one's coming in much faster, so we'll go ahead and close in around 5 seconds. All righty. So around 44% did attend the first webinar in the series, and 56% did not.
Excellent. Okay, well, thank you all very much for participating in those polls. It helps us to know who's out there. So without much further ado, let's quickly then provide an overview of what we covered in our first webinar. Like today, we started with providing some context as to why we're even talking about strategic restructuring, and we then reviewed some restructuring strategies such as joint programming, mergers and acquisitions, etc. And we spent some time reviewing tools to help you assess what changes, if any, might be right for your agency to undertake. So that we're all on the same page, here's a quick definition of strategic restructuring. This definition comes from the La Piana consulting firm, and they say this about strategic restructuring. Strategic restructuring occurs when two or more independent organizations establish an ongoing relationship to increase the administrative efficiency and or further the programmatic mission of one or more of the participating organizations through shared, transferred, or combined services, resources, or programs. So a quick note here, we know that some of you might be interested in making some major organizational changes, but that many of you might not be, or you may not be looking to involve other organizations in your proposed changes. And while we will hear from two organizations that have gone through some more intensive restructuring today, much of what we will be talking about is meant to be helpful no matter where you are or what you may be considering in your process of organizational change. So why do organizations consider restructuring? Typically, to preserve the organization's mission and services, to build capacity and increase efficiency, and or because the context of the work is changing. And it's this last point about context that is very applicable to us who work in the field of HIV today. So let's take a few minutes to consider the current context and how it was shaped. Before we look at how things have changed, let's look at how HIV services were conceptualized 3 to 4 years ago. Back then, we're talking maybe early 2010, HIV prevention consisted mostly of testing, and in particular, counseling and testing, and health education risk reduction. With respect to testing, we talked a lot about targeted testing for high-risk groups, and a lot of testing was done in non-clinical settings. And for HERR, we focused mostly on behavioral interventions for HIV-negative folks. Care services, consisting of primary medical care and essential support services, were largely Ryan White funded and were provided largely in ASOs and HIV specialty clinics. Treatment, specifically HIV medication for HIV-positive people, was thought of as a subset of care services with some potential to prevent forward transmission. There was some overlap between care and prevention, mostly with respect to prevention interventions with HIV-positive people or prevention with positives. Today, of course, is a very different picture. So let's now take a quick look at why that is. In 2010, the Affordable Care Act was signed and set in motion, and the first ever National HIV/AIDS strategy was released by President Obama and the Office of National AIDS Policy. In 2011, there were a number of scientific breakthroughs in the field which really solidified the concept of treatment as prevention. Also in 2011, a model known as the HIV treatment cascade was popularized on a national level by an article written by Dr. Edward Gardner and his colleagues. In 2012, we saw some major shifts in funding, in particular CDC's reallocation of funding for health departments, which in many ways redefined how we and our federal partners conceptualized HIV prevention. And now, in 2013, we find ourselves preparing for 2014 when Medicaid will be significantly expanded thanks to the Affordable Care Act, and health reform continues to unfold. So a lot has already happened, and there's even more about to happen in the near future. Let's take a quick look at some of these events. I'm sure many of you are very familiar with the National HIV/AIDS strategy, the first ever such blueprint for our domestic efforts in combating HIV. The strategy was released in 2010 and outlined 3 specific goals: to reduce new HIV infections, to increase access to care and improve health outcomes for people living with HIV, and to reduce HIV-related disparities. Then in 2011, the HBTN 052 clinical trial found that HIV-positive individuals who adhered to their antiretrovirals were 96% less likely to transmit HIV to their uninfected partners than those who delayed treatment. This study then convincingly demonstrated that ART could not only improve health outcomes for people living with HIV, but it could also prevent the transmission of HIV, and therefore, perhaps more than anything else, really drove home this concept of treatment as prevention. And here's a slide that's probably very familiar to many of you. This is what has become known as the HIV treatment cascade. This diagram, which was part of a 2011 article by Dr. Edward Gardner and his colleagues, is a simple way to depict the estimated number of people living with HIV who know their status, who are linked to HIV care, who are retained in HIV care, who need treatment, who are receiving treatment, and who are adherent to their treatment, and ultimately have an undetectable viral load. Unfortunately, as a result of drop-offs along the cascade, it's estimated that only between 19 to 28% of people living with HIV have undetectable viral loads. And we show you this slide because the treatment cascade has become a very popular tool that many jurisdictions are using to better understand their local epidemics. It's yet another indication of how things have shifted over the last few years. Speaking of shifts, the CDC introduced high-impact HIV in 2011 and really began implementing it in 2012 with new allocations for health department funding. CDC's new approach was designed to more closely match the geographic distribution of HIV with a stronger focus on supporting the highest impact prevention strategies. In particular, those strategies include testing, comprehensive PWP, with an emphasis on linkage and engagement in care, condom distribution, and policy initiatives. Tom's going to talk more about the Affordable Care Act and its impact on HIV services in a few minutes, so I'm just going to cover a couple important points here. In states that accept Medicaid expansion, non-disabled adults who make less than 133% of the federal poverty level will now qualify for Medicaid. There will be subsidies for those who make between 100 and 400% of the federal poverty level to purchase private insurance through state exchanges. Yet there will still be about 23 million people in the country without health insurance. The ACA also eliminates pre-existing condition exclusions, which is great news for people living with HIV. And ultimately, the rollout of the ACA means that many people living with HIV who currently don't have insurance and who get their HIV medical care paid for through the Ryan White program will get insurance through the ACA. One of the big questions then that everyone seems to be asking is, what does this mean for the Ryan White program since it's the payer of last resort? And Tom's going to talk a little bit more about that later in the webinar. Remember, again, this is how services were conceptualized in the recent past. And as a result of all these events we just talked about, the strategy, the breakthrough science, the ACA, et cetera, this is how services are beginning to be conceptualized now. In this diagram, concentric circles are used to depict how prevention care and treatment services overlap and relate to each other. This model actually comes from the work of the Los Angeles County HIV prevention and care planning bodies. Treatment services are defined as those services or interventions that involve HIV-related medical treatment, whether for HIV-positive individuals or for HIV-negative individuals, for example, PrEP and PEP. Care services and interventions are defined as all Ryan White core and support services, which also include medical treatment, and prevention services and interventions include all services and interventions meant to prevent the transmission or acquisition of HIV, including care and treatment services. So in this model, treatment services can be categorized as prevention services because of the potential impact of treatment on individual viral load. However, there are a few prevention activities, for example, behavioral interventions targeting high-risk HIV-negative folks that may not be categorized as either care or treatment. So again, a lot has changed. Speaking of change, many of the questions and comments we received from the last webinar were related to the difficulties of change and how to best manage change. So clearly, we can all agree that change can be hard. As this slide depicts, there are a number of reasons you will hear not to change. You'll hear things like, we can't take the chance, or we've always done it this way, I'm all for it, but ... we tried that before, there's not enough money, time, what have you. And my personal favorite here is, we're waiting for guidance on that. Unfortunately, our guest speakers today will have more to share about how to handle organizational change and all the challenges that come with it. I'll just leave you with this image and turn the controls over to Keisha McCurtis, who will talk about some things you can do right now to implement change.
Thank you. So now that AJ set the scene for us and helped us shape and define the context in the changing landscape, let's talk a little bit more about what we can do right now. The Office of the National AIDS Policy, or ONAP, is the White House Domestic Policy Council that's tasked with coordinating continuing efforts of the government to reduce the number of HIV infections across the U.S. And recently, ONAP hosted a series of regional meetings on the implementation of National HIV/AIDS Strategy, as well as the Affordable Care Act. And the meeting that was held here in Los Angeles was on February 14th, and the goal of the LA meeting was really to engage key stakeholders about ongoing challenges and successes of the strategy and ACA implementation. Kathleen Clannon, the medical director of the Alameda County Low-Income Health Program with the Alameda County Healthcare Service Agencies, was one of the panelists at the Los Angeles meeting. And we've mentioned already a little bit, and Tom will talk about this more, but health reform is really going to shift the way in which people living with HIV access care and treatment. And during her panel presentation, Kathleen focused on the changing balance between primary and specialty-based HIV care. And she shared some great recommendations that she's developed that highlight some of the ways that traditional HIV care clinicians and providers can adapt services to ensure that good care follows patients and clients wherever they go post-January 1st, 2014. I refer to Kathleen's series of recommendations as the 3 threes because she's developed a list of 3 things that clinicians can do, 3 things that CBOs can do, and 3 things that patients can do right now to prepare for the coming change. So what can community-based organizations or traditional service organizations do right now to prepare for coming change? To begin with, they can measure disparities in outcomes. And this can be challenging, we know, but it's imperative that we document the need. Next is to become familiar with the language and the concepts of the patient-centered medical home. Some elements of enriched care in patient-centered medical homes are found outside the clinic setting, and CBOs that speak the language of the insurer and understand the important elements of the managed care world will be at a distinct advantage. So for example, peer navigators are important elements of the managed care world and PCMH concepts, and many CBOs currently provide some form of patient or peer navigation, but those who aren't able to accurately describe that service in PCMH language will have a difficult time finding funding streams to support their work. And then finally, for CBOs, the last recommendation is to make a tight connection with one or more medical providers in this area, or in your area. So there will be an increased focus on medical care, and it will become increasingly difficult for agencies without links to medical settings to survive. We already have evidence of why CBOs will need tight connections with medical providers. So here, this is a screenshot from the CDC Effective Interventions website. CDC has added a few new tabs to their high-impact prevention workspace, most notably the biomedical intervention section and the medication adherence interventions. If we look a little closer at the appropriate settings for the various different adherence strategies that CDC plans to unroll or roll out, we can see that the appropriate settings for these soon-to-be packaged adherence strategies are in HIV primary care outpatient clinics, in community health centers, and in CBOs or AIDS service organizations with strong relationships to HIV clinics. So the second set of recommendations from Kathleen's 3 Threes are for patients. What can patients do right now to prepare for health reform? To begin with, pick one medical provider or case management agency and stick with them. It'll be important to choose a single agency or clinic to go to for help with eligibility and enrollment. Next is to open your mail. All information about eligibility and enrollment will come in the traditional snail mail fashion, so it's important that providers know how to reach patients in several different ways, and that if the mailing address changes, the providers know. And finally, to tell your story. Individual stories about how things don't go well are useful stories because they get rolled into advocacy that occurs at the state level. The third set of recommendations in the 3 Threes are for clinics or clinicians. I'll mention these just briefly. Tom's going to talk about them more in depth a little later. But contracting with your local Medicaid providers is important, as well as identifying a benefits counselor, whether that be in your own clinic or in a nearby local CBO, and getting recognized as a patient-centered medical home. Finally, we also wanted to share this new resource from healthcare.gov. You can find a few other recommendations on how best to prepare for coming health reform changes, notably for families and individuals. And this website will be included in our resource list at the end of the webinar. So now that we've sort of talked a little bit about the context and what you can do, we have some case studies. We're very lucky to have with us today 2 guest presenters who will be speaking about their experiences adapting to and preparing for the coming health reform changes. With us today are Peggy Anderson and Jury Candelario. They'll both be with us throughout the completion of the webinar, and they'll be available for questions at the end. So first, I would like to introduce Peggy Anderson, the Chief Operating Officer with AIDS Resource Center, Ohio. Peggy will share a little bit about her agency's experience with strategic restructuring in the Affordable Care Era. Thank you for joining us today, Peggy.
Thank you for having me. I appreciate the opportunity to share our story a little bit. Okay, so basically the organization that I've worked with for the last 12 or 13 years was the Columbus AIDS Task Force. I've been in Central Ohio, the 30-year organization. And then in 2008, we started really having some financial difficulties. And it got to the point where I actually thought we were going to have to close our doors. So I had been in charge once we realized that I had been in charge for about a week. I've been with the organization in other positions. But until that moment of then being in charge of everything and really talking with our bankers and with our CFO, realized we just can't keep going the way we are. So we did some immediate layoffs. We cut costs the best we could. And I made a call to the then CEO of AIDS Resource Center, Ohio, the previous pre-merged organization, and said to him, if we don't make it, I need you to come in and make sure that the clients are served in this area. And then also, if you need staff in this area, I would be happy to recommend some of mine. And so we started the conversation, do mergers make sense for us at this time? And really started digging in with our board members. We assigned committees from both organizations from the board to do a due diligence process and really look at all of the issues that made sense for us either to combine, what didn't make sense. And so we really started a 1.5-year long process to make that happen. And it was a tedious process and sometimes an aggravating process, but it was a successful process. Next slide, please. Thankfully, our organizations had a very similar and common mission and some common ground for us to work from. And so we were all, both organizations, really focused on the basic AIDS service organization services. We had the prevention, we had case management. In the Columbus region, though, we also had a Part C grant through Brian White, and we were accredited to provide mental health treatment, which was something that was a benefit for us. And then we also, after the merger of the Columbus AIDS Task Force and AIDS Resource Center, Ohio, a couple months later, merged again with a smaller organization, the Ohio AIDS Coalition, that focused primarily on educating both clients and providers about how to advocate for themselves in their treatment. Sometimes it was about things like Hep C that they needed to know about. And so having those three organizations as one really made us who we are today. Next slide, please. This map kind of shows you in Ohio. The red ribbons are where we currently have offices, except for the one in the right-hand corner in the Cleveland area. We have prevention in all of the areas and case management in most of those areas. And then in the striped areas, mostly what we do are provide the client education and provider education. This happened slowly. Originally, all of those areas kind of had their own organizations and their own entities, sometimes very small, sometimes a little larger. And over the years, as I think many people recognize, financial instability for all of our organizations, or sometimes just realizing it might come down the road, made us all talk and figure out, should we look at collaborating? And so when ARC Ohio and the Columbus AIDS Task Force merged, we each had about, I think one group had 27 counties and another one had close to 40. So when we merged, we ended up taking about 3/4 of the state in regards to case management services. Next slide, please. Once we merged, it made us more stable financially and made us more stable, or at least we'll be able to spread the expertise that we had around to other areas of the state. And so it allowed us to open up a medical center and pharmacy. And I won't talk about this too much because another presenter will later. But it allowed us to have the financial stability to actually open up a clinic. We've had the Part C grant for years, but had always passed that money on to a medical provider to provide that care. And as many of us, I think, were doing that, we got a call from HRSA saying, okay, it's time for you to actually provide your own care, or you likely won't have this grant in the future. And so it was kind of the impetus for us to really move quickly. We merged in July 2011, July 1, and we opened up our clinic. I think we got the call in September of that year from HRSA, and we actually opened up our clinic in September, clinic and pharmacy in September of 2012. And so this merger has allowed us to grow in a way that we wouldn't have been able to do as a single organization. It also allowed us to share our expertise on the prevention side. Both of our organizations had submitted multiple CDC grants over the years and had never gotten one directly. And right before the merger, and we talked about the merger heavily in our grant application, we were awarded a CDC grant for the Central Ohio, the Columbus region. And so we were very excited about that opportunity, and I really think it was primarily because of the sustainability and the strength of our organization post-merger. Next slide, please. I'm going to go through a lot of these a little more quickly. I'm not a fan of reading them, so feel free to ask questions later. But one of the things that we get asked is why a pharmacy or why any earned income project, and I think many of us are on this call because we realize our organizations need income or revenue coming in that's not attached to grants. Because we may have, and in our case we have a lot of prevention programs, testing programs that are either not funded or underfunded, and we believe in their outcomes and their goals and their purpose. And so our need to have our own revenue to fund some of those programs are why we keep doing this. Next slide, please. When we were looking at merger, a lot of the things that we considered were, are we serving the same folks? And we were. We were serving the exact same demographics. We were serving different regions, and that was our primary difference in the state. But we were offering the same programs and using similar outcome measures and those kinds of things. And so it made sense for us to save on the things like financial support, instead of having 2 accounting systems, 2 donor systems, 2 client systems, having one that we combine. And so we've been working really hard on making sure that made sense to us. And was it better or worse if we were going to consider merging? So we streamlined a lot of those things. Next slide, please. If you are going to merge, you need to pay attention to a lot of things. One of the things that was a big sticking issue, and I'm sure it's that way with most organizations that decide to merge, is who's the surviving entity? Which organization continues? What's going to be the name of the organization? And it's a hard decision for board members. It's hard for donors. It's hard for clients, and oftentimes for staff. One of the things we really sat down and looked at is what makes more sense. And so what ended up happening with us is the Columbus AIDS Task Force is actually the surviving entity. And the only reason we chose to do that was because we had accreditation for our mental health programs. We had some certifications through the state to bill Medicaid for services like our behavioral health program. And we had the Part C grant. If we had dissolved the Columbus AIDS Task Force organization, we would have had to start from scratch with many of those accreditations and those grants, and it was more work for us not to do it the opposite way. So just really think about what makes sense and make it not emotional, which is really hard to do in those situations. We re-examined all of our programs and our events to make sure they were mission fit. We looked at, does it make sense in one city in the state and maybe not in. One of the things that was really the focus of deciding whether to merge or not was making sure that the clients really didn't know, unless it was a good reason, that anything had happened. And so, when we merged and the media were calling to try to interview clients to see what they thought of the merger, we actually had to prep the clients to even talk about the merger because so many of them didn't even realize what was happening. And it was a good thing. Next slide, please. I think to remember, one of the slides that you saw earlier was the 50 reasons not to, and I think I heard most of those at one point or another. You really need to have a neutral party that can come in and help kind of sort through the emotions of merger and what leader stays, what organization stays. You have to consider leadership style, board style, the staff culture. All of those things are big issues, and if you don't pay attention to them, they can explode and be hard to then manage from then on out. Next slide, please. I think one of the things I'd like to just mention is communication is key. Your senior leadership and sometimes even your lower managers need to know what's going on, but they also need to know what to keep confidential, what script they are allowed to talk about. And you almost over-communicate as much as you can because a lot of things, rumors start happening, and that's when things go wrong. Quickly through the last slides, I would say if you're married to your way and only your way, the merger process will be either nearly impossible or very painful. We don't have emotional attachments to everything, but I think sometimes in a merger, we want to hold on to, hey, this is my office supply guy, and I'm not switching to anyone else. And you kind of have to give up those things and be willing to move along. What's really crucial as well is the senior leadership has to believe in the merger. There were many points during this process where, as the CEO of the Columbus AIDS Task Force, I could have said to my board members, this is not a good idea, and we shouldn't do it, and it would have changed the outcome. And so senior leadership really has to buy into it and be on board. Not that the board can't take it away from and make those decisions on their own, but oftentimes they rely on the executive director or the CEO to help guide them in those decisions. So that's very important. And I would also say the last point on this slide, we're still kind of finding some of this. We, the former entities just didn't go away. You still have to do things for them, get their audits finished, finish their 990s, make sure the staff who worked for that organization got their W-2s, and et cetera. We forgot some of that from time to time, and we're late doing some of those things. And so you have to be on top of all of that just to make sure that the organization kind of continues. Next slide. I think I already talked through this one, so we'll skip to the next one. One of the things that I think is really crucial, and it's surprising me a little bit, is the staff particularly feeling a loss of identity and a loss of history with our organization. Again, the Columbus-based organization was the surviving entity, but because we changed our name, there were so many emotions and sentimental feelings about the name. There were staff, I've been with the organization at that point 13 years, and there were staff who had been there 2 years who were in my office crying about the name change. And I wasn't prepared for that. I didn't think that that would be the case. So just really paying attention to your staff, keeping an eye on where their emotions are, what they're saying in the community, and just making your decisions, but make sure you're thinking about them as well. Next slide, please. I think pretty much the last slide. Merging everything is difficult. Merging finance can be painful. You have multiple bank accounts, you have multiple accounting systems. In our case, we had multiple fiscal years that we were using, multiple payroll systems. So just give yourself time and make sure you give a lot of extra thought and process through that. And then I think I would end with saying, be careful what you, again, the confidentiality thing. You have community members, you have donors, you have clients come up and kind of ask you, well, what's really going on? And I think you really have to be prepared to stick to the script and include them, but do it in a way that's respectful of the process in both organizations. You're going to get, or potentially could get, donors and other community members who are upset, they're fearful, they're worried of what's going to happen, and you just have to really believe in it and move forward. So I think that's kind of my hopefully 10 minutes or less spiel on what we went through, and I'll be around for questions at the end.
Thank you, Peggy. It's now my pleasure to present Jerry Candelario, the Chief Executive Officer with APAIT Health Center. Jerry will also share a little about his agency's experience with strategic restructuring in the Affordable Care Act. Welcome, Jerry.
Good afternoon, everyone. Thank you. And thank you, Peggy. I think I'll certainly be cross-referencing a lot of the lessons learned that you have shared, because we certainly have some similarities. If you can go to the next slide, please. So APAIT Health Center is a 25-year-old organization, and we initially have been known as Asian Pacific AIDS Intervention Team, really coming out of the roots of the HIV/AIDS epidemic back in the 80s and 90s, and we are a recent organization that is transitioning from an AIDS service organization to now a community health clinic. And if you look at the vision and mission in here, and I'm not going to really read it, you can see it for yourself. Part of our transition as an organization into this restructuring is really being able to embrace change and being able to really, from a strategic standpoint, look at why it was important for us in an AIDS service organization and being part of the healthcare movement to move into this healthcare setting. So I just wanted to emphasize, some of the earlier slides earlier about the importance of embracing change, planning for change, implementing change, and really monitoring change, and at the same time going through this process is being transparent through that process. And as you'll see here, APAIT Health Center, that's actually a name that we've been known for, but we are also going through this transition of rebranding as we speak, and that's some of the transition that we're going through as an organization. Next slide, please. So the next slide is really specific to what type of services we've been known for. As AJ had shared earlier, a lot of things that are listed here as far as programming and services are within the tradition of what AIDS service organizations have been known to do. We are an organization that have HIV prevention and testing. We have psychosocial support services. Some of the traditional programming in the past for HIV/AIDS services like self-help programs, treatment adherence, mental health. And over time, you'll see here some of the kind of more integrated services that we've added in our HIV/AIDS cadre, including behavioral health, and focusing really on monitoring the progress or the evolution of the HIV/AIDS epidemic, and focusing on comorbidity issues like mental health and substance use. So several years ago, we've developed this behavioral health component or programming in our HIV/AIDS programs. And as part of that, we have a relatively robust mental health programs. We also have an outpatient substance use treatment program. And next slide, please. So why we restructured really essentially started out officially in 2008 through a strategic planning process. And through this internal strategic planning priority process, we identified as one of our primary focus the expansion to primary care services, again with the notion that HIV/AIDS is part of the healthcare movement, and frankly it's also from an opportunity to expand and to sustain ourselves. And during that time in 2008, as you all probably recall, is the beginning of the Obama administration. So part of that process really is having this formal strategic planning process where we said we want to do this. And through a full year of a stakeholder needs assessment and process, one of the things that came out of that is our patients really wanted to have an HIV/AIDS clinic. And in 2010, we started out kind of going through that process and integrated this chronic care model into our cadre of programming. And this is specifically in addressing the comorbidity of HIV/AIDS, mental health, and substance use issues. And at that time, we had an initial partnership with another federally qualified healthcare center locally. And then in 2011, as we were going through the strategic planning process and really the process of, on a yearly basis, looking at what are the action plans we were going to take, in 2011, we relocated to a new space, and it is a medically underserved area. And during that same time, we received a planning grant from HRSA to really support our efforts to transition from an AIDS service organization to a primary care health center. And then finally, last year in 2012 is when we finally got our designation as a community health center. So next slide, please. So how we really restructured, again, very similar to what Ohio has done, is really having this full-on stakeholder action planning on an annual basis and monitoring the progress of that, making sure that we were on track to what we said we were going to do and how we were going to develop our transition from an AIDS service organization to a primary care clinic. And part of that is this ongoing service integration, and that service integration really is about, how do we go from just doing HIV/AIDS to this primary care beast, so to speak, and merging that. And also part of that process is just monitoring, the resources that you have. What's unique about our particular organization is we are part of a larger parent company that really has supported us. And if there is a strategic restructuring partner in this process, it's really our parent company, which is called Special Service for Groups, and they are primarily a behavioral health service organization. So part of that service integration, again, is looking at what are the types of how do we merge our existing HIV/AIDS programming to a primary care, and part of the services that we've added on is of course, an HIV specialty clinic, but also going really the extreme end of actually developing a primary care health center, not just addressing HIV/AIDS, but family practice as well. And we have been engaged, for instance, with a number of consultants. Some of them are part of this panel, and really developing that. And one of the things that I've learned through this process, and the next slide, please, and again, is the importance of knowing some of the challenges in the implementation of ACA, being knowledgeable with the patient-centered medical home versus the AIDS specialty care. Very much similar to what was stressed earlier from Dr. Kathleen Clannon's presentation, the importance of what is it that is different from the model that we're doing now in order for us to meet the objectives of becoming a patient-centered medical home, being team-patient relationship-driven, and then this whole notion about becoming really managed care savvy. As you all know, particularly in California, we are in the middle of the healthcare exchange, or really nationally. So being able to navigate that process and really keeping up with the policy movements within ACA, it's almost one of those things that you have to make sure from a policy perspective you are keeping aware of the different things that are going on in preparation for 2014. I also wanted to stress again the importance of collaboration and also who your competitors are, making sure that you also aren't duplicating services. And one of my biggest lessons learned in this process is really, at first we thought we could transition this within 6 months to a year. We started this process back in 2008, and here we are almost 5 years later. We're still in transition, and that's actually essentially one of the important lessons we are continuing to learn from, is that change is definitely an ongoing transition, and that you should continue to monitor that and really just embracing the change and being able to be flexible and adjust through the transition process. And I will be around for questions and answers later.
Great, thank you so much. This is Tom Donahoe. We're going to save the questions to the end, and to keep us on time, Patrick, I'm going to skip through the polls that we had planned.
Sure thing.
Because we basically just wanted to see how people were accessing information about the Affordable Care Act and how many training sessions they have already been to. But I think the take-home message there is that certainly by spring, you want to have a couple webinars and trainings under your belt. So let me begin by talking about going back to Kathleen Clannon's presentation about what clinicians and clinics can do now. So Keisha already covered this a little bit, and I'm going to talk a little bit more about Affordable Care Act implementation and people living with HIV, expanding on what we said in the last webinar while answering some of the frequently asked questions from the first webinar. So many of these questions seem to come from people who worked in federally qualified health centers or community health centers, so I thought I would expand on what Keisha said before and share some more about what Dr. Kathleen Clannon proposed at the ONAP meeting last month in Los Angeles. So she said, as Keisha shared, that the 3 things that HIV clinicians and clinics can do right now are to contract with your local Medicaid providers, identify a benefits counselor within your clinic, and get recognized as a patient-centered medical home and learn that patient-centered medical home language. The Affordable Care Act will expand Medicaid in most states. It will subsidize private insurance for middle-income patients, making 100 to 400% of the federal poverty level, and it will increasingly ask that clinicians and clinics and their partners understand and become familiar with the concepts of a patient-centered medical home. So looking at the frequently asked questions from the first webinar, I compiled similar questions into 3 broad questions in the next 3 slides. Remember, Ryan White still will be the payer of last resort for patients. So one of the questions was, if our state does not accept Medicaid expansion, how will our clients cover the cost of HIV medications? Once again, Ryan White will be the payer of last resort. States that do not offer Medicaid expansion will still have Ryan White and subsidize private insurance through the exchanges for patients. It will be extremely important for moderate income people living with HIV, those people I mentioned before that make between 100 and 400% of the federal poverty level, to understand their rights and obligations under the state exchanges. This is why benefits counselors, case managers, and anyone helping HIV patients should also keep abreast of these programs, which will launch this summer for enrollment in October and for insurance to begin January of 2014. People who are offered affordable health insurance, they get an offer that's less than 9.5% of their income, will need to understand how the insurance works and how subsidies and possible help with co-payments might impact them. So the other sort of general question was, how does a CBO prepare for new payers and billing systems? So if you're a CBO that's currently connected to a clinic, your clinic administrators are likely working on these issues right now, as I'm sure that our other leaders from clinics can talk about in the question and answer session. So probably they're reviewing their existing contracts with Medicaid providers, waiting for information on upcoming state exchanges, and deciding whether to be listed as a primary care or specialty care clinic. If you're a CBO that is not connected with a clinic or clinics, as we said in the first webinar, now is the time to form those relationships and explore how you can work with clinics, speak their language in terms of patient-centered medical home, billing, and other issues, and investigate the types of programs and services you might partner around. For example, prevention, retention and care, partner services, may be billable services in the future that an outside organization could do. Form and solidify these clinic relationships now. Plan to make them integrated services and more than just written MOUs that go into files. Remember, services do not need to be co-located to be integrated. And then the final general question was, what about our patients who won't qualify for Medicaid expansion or don't receive affordable offers of affordable insurance through the health exchanges? So that could be people who don't get affordable offers of insurance, undocumented immigrants, and legal immigrants who are here less than 5 years. So remember, Ryan White will remain the payer of last resort for those who don't qualify for the Affordable Care Act implementation or don't get an offer of affordable insurance through the exchanges. Remember, when you're talking to legal residents, you also have to calculate in them. We're talking about whether or not they're here 5 years starting in January of 2014. So someone who's been here 4 years and 8 months is probably going to qualify for the exchanges. Some people, too, may still wish to purchase insurance through an exchange even if they don't get an affordable offer of insurance, if it's more than, say, it's just 10% of their income. This will be a very small group of people, but these are considerations that fully informed individuals will need to make in the coming year. So ADAP enrollers, case managers, and benefits counselors are going to need to understand the law, the exchanges, possible subsidies and assistance, and the types of decisions that people will be making. So all of these are just different organizations that have developed action steps for you to look at on their website, which we've included in the resources section. So these are just some images from the different websites you can go to understand better those action steps. And HRSA itself has just come out with a new website, which we're going to give you a link to a little bit later, as has the HIV Medical Association. So to close, I want to go back to those resources we said we would share with you and keep us on time. So the first is La Piana Consulting. Once again, for strategic restructuring information, they're the most respected resource. Also, HRSA, as I mentioned, has developed Affordable Care Act specific resources. And you would definitely want to visit the HRSA Target Center website. Target Center is technical assistance, resources, guidance, education, and training. I think I mentioned on the last webinar that they had lots of great presentations at the All Grantees meeting in November, and they're continuing to monitor integration of the Affordable Care Act into HIV care and share published reports, advisories, and tools. And finally, the CDC has a lot of information on their website about many of the changes to the landscape we discussed today. At effectiveinterventions.org, for example, you can read a lot more about high-impact prevention, linkage to care strategies, biomedical and behavioral interventions, and more. CDC will also be diffusing new medication adherence interventions very soon. You can see that on the tab here, medication adherence. So all of this you can find here on this resource list, which I think I'll let it stay on the screen there in case some of you want to come back and write any of these down. And then finally, here's the contact information for AJ, Keisha, and myself. So we've got a few minutes left for questions and answers. If you want to take some, Patrick, or just read them to us.
Sure, we don't have that many. One of the common questions we always get is if the slides and presentation will be available after the webinar, and yes, they will. You can go to our website. You can see in the lower right corner, sharedaction.org or sharedactionhd.org, and they will be up on a program toolkit probably in a few hours, I want to say. And as well, if you're curious about more information about the Affordable Care Act, under that same toolkit, we just had a webinar last week with an expert on public health policy who presented on the Affordable Care Act and how it relates to HIV and AIDS. So you can look that webinar up as well. And one question I'm seeing is, per federal guidelines, does a PCMH have to treat HIV?
Yeah, it's not. I don't think it's a requirement of this PCMH model, but you know, obviously you couldn't discriminate against someone living with HIV.
All right. Let's leave it up for questions just for a little longer, and if not, we can go ahead and close the webinar out because we're already we're nearing the end.
I just wanted to, again, thank Jury and Peggy, the leaders from clinics who've gone through this process for the amazing information they were able to share with everyone today. And invite them for any final comments, if you had any final comments to make.
This is Jury. I guess I just want to
This is Peggy. Thanks for having me.
Jury, why don't you go first and then Peggy?
Okay. Again, I just want to reiterate the importance of being patient and, being able to just embrace change as you go through this process. I know that we have a lot of, roots and change is naturally kind of a very hard thing to do, but it's just really important in order to sustain ourselves and also innovate and really address the needs of our community. It's really important that we be part of that change, and that is an evolution of what we need to continue to do as organizations.
Great, thank you. Peggy?
Yeah, I would just like to echo Jerry's comments and to say it's just important to do your research, do your homework, know where you're going, but also be flexible enough that if you get in the middle and it doesn't make sense and you have your data to change course or change a program, to be open to that change and that flexibility, because this is about the sustainability of all services for those living with HIV, and if we're not going to be around to do it, those in the community will suffer. And good luck.
Thank you. We still have 3 minutes if anybody has any other questions out there.
We had one question for clarification. 1 second. One person thought that to be considered a PCMH, the center had to treat certain types of chronic conditions. Is that correct?
Yeah. So there's a lot in the PCMH language, and there's a lot of steps to go through to get that certification. And so once again, everybody, whether you're a case manager, a clinician, or a CEO or COO like we have on the line, you're going to need to be able to be familiar with that and speak that language.
Okay. So with that said, I want to thank Tom, AJ, Keisha, Jury, and Peggy for presenting today. It was a great presentation. And so everyone knows, we have educational materials up on our website at sharedaction.org or sharedactionhd.org under the program toolkit. We have technical bulletins and broadsheets on a variety of topics. Please go ahead and take the post-webinar survey. You will receive it right when this webinar ends, as well as as a link once you get the final email from GoToWebinar after the webinar is over. So please take the time to complete the survey. This is where we get feedback from you guys about how the webinar went, what we can do to improve it, and just to remind you that these webinars are for you, so we want to work to improve them as much as we possibly can. So please go ahead and take the post-webinar survey. And here is our information up at Shared Action and for Shared Action HD. If you'd like to contact us for any additional CBO services, you can go ahead and contact Oscar Marquez, and his information is located on the screen right now. And with that said, thank you for attending. This was a great webinar, and I was glad to have everyone here.
Thank you, everyone. Thank you.
Thank you.